Hi everyone, my name is Dr. Pillai. I'm an endocrinologist working in the National Health Service in UK. Today I'm going to talk to you about hyponatremia and how we are going to manage it and what are the things to look for when you get a patient with hyponatremia. What are the common pitfalls? I have approximately 30 slides, so this presentation should last about 30 minutes. So let's go for it. So the learning objectives will be, first of all, what is hyponatremia and how you evaluate a patient with hyponatremia, what are the essential biochemical tests you need to do, what are the symptoms of hyponatremia, and what is syndrome of inappropriate ADH secretion, SAADH, and how to avoid overcorrection and thereby prevent osmotic demyelination. So if you look at this slide, you can see that hyponatremia is defined by the severity into mild, moderate, and severe. It depends on the level of sodium in your blood. When it is between 135 and 130, it is mild, and between 125 and 129, it is moderate, and less than 125 is considered as severe. Symptoms may not always correlate with what you see on this slide, but if somebody develops acute severe hyponatremia, you can see they have some form of confusion, vomiting, headache, so all signs of CNS irritation due to the low sodium levels. Sometimes you can see very low GCS levels, seizures. These are extreme forms of hyponatremia, which when developed over a very relatively narrow period of time, it can give you these symptoms. The next slide is about a case. So we'll go through this throughout this presentation to work out our way of approaching hyponatremia. So in this, we have an 87-year-old lady who's got heart failure, atrial fibrillation, hypertension, and diabetes. She came to the emergency department with a history of diarrhea for 3 days, and she's on those medications like furosemide, ramipril, omeprazole, apixaban, bisoprolol. And she has had a first seizure in the emergency department and has got a very low GCS, Glasgow Coma Scale. And her venous blood gas has shown a sodium of 105. So managing this lady, what would be the next best step once you stabilize her airway, breathing, and circulation? So this is presents an extreme case of hyponatremia, which is quite symptomatic. So you can think about what all things you might need to do. Of course, you need to correct the hyponatremia. So in this presentation, I will discuss the ways in which you can correct the hyponatremia and what are the safe levels of correction and what are the things to avoid complications from overcorrecting hyponatremia and what are the common causes. We'll go through all these things. Like many things in clinical medicine, when you assess a patient with hyponatremia, you have to go both with clinical and biochemical investigations. So let's think about hyponatremia as something like this. So you have a fixed amount of sodium in your body and you have got water as well. So when there is excess of water, it dilutes some sodium levels in the body and thereby giving you hyponatremia. So all the conditions where you get an excess of body water, you can get hyponatremia. You can also get hyponatremia where there is excess solute loss, either by diarrhea or by vomiting, where you lose salt through these pathways. So in this lady, as you can probably see, she's feeling better and her sodium has improved to 111. Her GCS was very low, which is improved to 15. So what treatment we might have given to this lady? If you think about, she had symptomatic hyponatremia, which was requiring medications to rapidly correct her sodium levels. So the medication we have given was hypertonic saline. You have different strengths. Usually we use 2.7% or 3% of hypertonic saline to correct hyponatremia acutely. And the important thing of this is to correct and then monitor what is happening. So for the sake of discussion, I have included here that she has done a course of prednisolone for the past year. And she says that because of the diarrhea, not feeling very well, she was not taking the prednisolone. So what would you do next? So this question is basically to highlight the importance of thinking about different causes which can give you hyponatremia. In this lady, she's on long-term steroids. As you know, this can cause adrenal suppression, and that can indirectly cause hyponatremia. So if she was not taking her medication for a long time and coming in with a hyponatremia, and that presentation, you might need to consider giving her some form of glucocorticoid, usually hydrocortisone intravenously. So I'm an endocrinologist, so there are different causes for hyponatremia, both endocrine and non-endocrine causes. Out of the endocrine causes, these are the 4 different hormones we are interested in when somebody comes in with a hyponatremia. The first hormone is ADH, which is antidiuretic hormone. Then you have the renin, angiotensin, aldosterone system. You have your cortisol, and you also have this thyroid function, TSH, thyroid stimulating hormone. The deficiency or excess of these hormones, especially ADH, can result in hyponatremia. So we'll go through this in the next few slides. Before that, you can see that we have seen different hormones controlling sodium homeostasis in the body, and out of which I will take your attention to these 2 hormones. One is aldosterone, the next is ADH. So ADH is mainly working on its way on the collecting duct, where it opens up aquaporins and helps to improve absorption of water. So when you're dehydrated, this is what happens. ADH is released and it acts on the collecting duct and causes the aquaporin channels to open up, helping to absorb water. Aldosterone also works at the collecting duct, but it can also work at the distal convoluted tubule as well. So when the body's effective circulatory volume is low, it activates the renin, aldosterone axis, and then aldosterone levels increases, which tries to retain sodium and water, thereby establishing the hypervolemia to back to the euvolemic state. So out of which, if you look at this next slide, you can see that ADH, the antidiuretic hormone, so you can look at the name and see it is antidiuresis, so it is against passing water, so it's against diuresis, so it retains water. So when you are feeling thirsty, the hypothalamus detects this and it releases the antidiuretic hormone or vasopressin to the posterior part of the pituitary, where it is stored, and then it is released in the circulation when the osmolality of the body is low, and it goes to the kidneys, where it helps to reabsorb water, and then the blood water, the volemic state is restored. Then that will further cause the ADH reduction and ADH production, and homeostasis is maintained like that. So osmolality is one of the main important things which determines the production of ADH. So what is osmolality? Osmolality is a kind of indirect measure of your solutes and water in the body. So you can see that it's usually between 275 to 295 milliosmoles per kilogram in the adult and elderly. So most of the time when you assess a patient with a hyponatremia, there won't be any osmolality available immediately, because it might take a few hours for the labs to process, But you can calculate this with the available values of sodium, multiply with 2 and then add your glucose and urea. That can give you an indication of what might be the osmolality even before the lab value comes in. So you call it hypotonic or true hyponatremia when your osmolality is low, that is less than 275. You call it hypertonic when obviously the osmolality is high, can be caused by hyperglycemia or mannitol therapy. You can also get isotonic or pseudo hyponatremia with excess of triglycerides in the blood or proteins in the blood, especially after immunoglobulin therapy. We'll go to the next slide. Out of the true hyponatremia, you classify this into hypovolemic, euvolemic, and hypervolemic. So as the name suggests, hypovolemic means you don't have enough circulatory volume in the body or dehydrated, causing you to have hyponatremia. Euvolemic, it means your volume levels are stable, which is not increased or decreased, and that is giving you hyponatremia. And in hypervolemic, you get an excess of body water, thereby causing dilution and giving you hyponatremia, especially in volume overload stages like heart failure or kidney failure, nephrotic syndrome, etc. So these are the 3 most important tests you need to do when somebody comes in with a hyponatremia. As you can see, we have already talked about serum osmolality. This will give you an idea about what sort of hyponatremia. Is it true hyponatremia, or is it caused by either pseudo hyponatremia? Then you can also get urine osmolality. This I will come back to in a minute, which is very important to find out if the urine osmolality is actually reflecting the serum osmolality. So if the serum osmolality is low, urine osmolality should be low because the body has got a lot of water and the kidneys are trying to excrete as much as possible to keep the urine osmolality in the lower side. Out of this, the third one is urine sodium. I would say this is the most important test which will help you to identify the cause of a hyponatremia, urine sodium. So you send a sample of your urine for osmolality and urine sodium. Then if you come back to this slide, this is what I have told so far. You can see that hypotonic, you have hypovolemia, euvolemia, and hypervolemia. If you look at this urine sodium, you can see that in 2 conditions, your urine sodium is less than 20. When you have diarrhea, vomiting, what happens is your body is trying to conserve as much as sodium as possible. So your urine does not contain much of sodium. So your urine sodium will be low. And also in nephrotic syndrome and cirrhosis and cardiac failure, because of the secondary hyperaldosteronism, you can get another place where your urine sodium is less than 20.